Very good morning, everybody. The past few classes we have been discussing about various aspects of fluorides in relation to dentistry. We have so far covered a basic introduction to fluorides, the mechanism of action, metabolism, acute fluoride toxicity, chronic fluoride toxicity, and defluoridation. The last class was on defluoridation. Today's class will be talking about the therapeutic aspect of fluoride. So when we talk regarding the benefits of fluoride in relation to caries prevention, we have two broad headings under which we will be discussing. One is called the topical fluorides and other is called systemic fluorides. So today's class will be on topical fluorides. So first, coming to the definition of topical fluorides, as you are aware of the term topical and systemic, topical fluorides refer to those delivery systems of fluoride which are locally applied onto the tooth structure for local chemical reactions to occur. So unlike systemic, which is consumed or which is ingested, which is absorbed into the circulation and reaches the tooth via saliva or GCF, your topical fluorides are directly applied onto the tooth structure. So whatever effect it is exerting is on a local area, that is directly on the tooth structure, and that is what is known as topical fluoride. So when we talk about the mechanism of action of topical fluoride, we have already had a very detailed class on what are the 5 different mechanisms by which fluoride act in preventing caries. Of all these 5 mechanisms, if you remember, there were 2 mechanisms that were exclusively systemic. The first one was under the heading called increased enamel resistance or reduced enamel solubility. You had a mechanism wherein there is a theory called as carbonate theory. That is, carbonate is present as an impurity during tooth development and it is the weakest portion of the tooth. If fluoride is given during the time teeth are developing, the carbonated hydroxyapatite is replaced with fluorapatite. So that is a very exclusively systemic effect. The next is the alteration in tooth morphology. So this also has to happen during the time teeth are developing. So when during the time teeth are developing, if fluoride has to reach the developing teeth, it has to be via systemic route. So other than these two mechanisms, all other mechanism of action holds good when you talk about topical fluorides. So I repeat, the mechanisms of action of topical fluorides are: first is increased enamel resistance or reduced enamel solubility. The mechanism is as we had explained earlier, except that the carbonate theory is not under this topical effect. The second is increased rate of post-eruptive maturation of enamel, a very important mechanism. Remineralization of incipient lesion, and of course the interference with plaque microorganisms, where it inhibits the anaerobic glycolysis. It inhibits the enzyme called enolase. We have discussed it in detail in the previous classes. Next, coming to what are the ideal ages of application of fluoride topically for caries prevention. Ideally, 4 age groups are recommended. The age groups recommended are 3 years, 7 years, 11 years and 13 years. The main reason for recommending these 4 age groups are, it is during these 4 age groups that you see a lot of hypomineralized enamel. As I have already told you in the previous classes, the hypomineralized enamel is the enamel which you can see in a freshly erupted tooth. As soon as the tooth erupts into the oral cavity, it is not 100% mineralized. You find areas where mineralization is not yet complete. These could be the enamel tufts or enamel spindles or enamel lamellae. They are known as hypomineralized enamel. And usually what happens is, over a period of a few months, this gets mineralized by a process called as post-eruptive maturation. So this fluoride, when applied topically, this is the ideal time of application because during 3 years you see the eruption of primary molars, 7 years the eruption of central incisors and first molars, 11 years the premolars and 13 years the second molars. So in these 4 age groups, it is the time that coincides with the eruption of teeth. You find a lot of hypomineralized enamel which are susceptible to dental caries. And if fluoride is given topically at these 4 age groups, it increases the rate of post-eruptive maturation. The main mechanism that is acting here is increased rate of post-eruptive maturation, and hence for prevention of caries, these 4 age groups are ideally recommended: 3 years, 7 years, 11 years and 13 years, corresponding to the eruption pattern of teeth. Next, why do you require topical fluorides? I told you there are two mechanisms of delivery of fluoride. One is topical, the other is systemic. Both has its own advantages and limitations. Systemic fluoride is one of the most cost-effective methods of caries control. That is, we'll talk about systemic fluorides in the next class. That is, usually fluorides are delivered systemically either through water or through salt or through milk. But this is comparatively very much cost-effective compared to topical fluorides. But even then, what is the rationale of use of topical fluoride? When we are talking about water fluoridation studies, one study that is very important is called the Thiel-Kuhlenberg study. Okay, this is a water fluoridation study where Thiel is a town which was artificially fluoridated the drinking water, and Kuhlenberg is a town which acted as control, and that study is known as the Thiel-Kuhlenberg study. And this study, when the surface-wise reduction of caries was measured, it was seen that there was maximum reduction in the smooth surface caries, which is almost 87%. There was 75% reduction in the proximal caries and around only 37% reduction in the pit and fissure caries. So this is a systemic method of fluoride delivery. When fluoride is given through drinking water, it is secreted through the saliva. That fluoride, what happens is, it does not reach the deep pits and fissures, because we all know pits and fissures are usually covered by a layer of pellicle or food debris. So whatever fluoride gets delivered through saliva does not go into the pits and fissures. So most of the systemic benefit of fluoride is on smooth surface caries and proximal caries, and there is a minimum effect on reduction of pit and fissure caries. Another probable reason is around the pits and fissures, the thickness of enamel is very less. So the amount of fluoride incorporated during development is also very less, and hence because of these factors, and especially with the outcome of Thiel-Kuhlenberg study, it was proved that the systemic fluorides are least effective on pit and fissure caries, and hence different mechanism was sought, and that is why we have topical fluorides. Even though it is not as cost effective as systemic fluoride, the main target for topical fluoride is always prevention of pit and fissure caries. Next, coming to how do you classify topical fluorides, depending on the on who is applying the topical fluoride. If the professional is applying, the dentists are applying, it is called as professionally applied topical fluorides, and if the patient is applying on their own, it is known as self-applied topical fluorides. So obviously, professionally applied topical fluorides require a skill and expertise, and most of these fluoride compounds are having high potency. They have very high concentration of fluoride, usually greater than 5,000 parts per million. And when you talk about self-applied topical fluoride, the patient applies it on their own. And the most common examples for self-applied topical fluorides are your fluoridated dentifrices or toothpaste and mouthwashes. This patient does apply on their own, but because they are applying it on their own, the amount of fluoride present in these forms of delivery are very less restricted to often not more than say 1000 or 1500 ppm. Usually it is between 2200 to 1000 ppm. So these are the self-applied topical fluorides. So the classification of topical fluorides is based on the application about who is applying. It is professionally applied topical fluorides and self-applied topical fluorides. With the same headings, you can also suggest another classification. The professionally applied topical fluorides are also known as high potency topical fluorides, and self-applied are known as low potency topical fluorides. So first we shall discuss about what are the professionally applied topical fluorides or topical fluorides that are applied by the operator. Okay, so currently the methods of delivery of topical fluorides professionally include the fluoridated solutions, gels, prophylactic paste, and rinses. So how do we deliver, or what are the methods of delivery of topical fluorides professionally? Okay, these are the examples. There are 6 ways by which a professionally applied topical fluoride can be delivered. One is the solution, second is the gel, third is thixotropic gel, fourth is the foam, fifth is the prophylactic paste, and sixth is fluoride varnish. It is only the method of delivery that differs. We will later discuss which are the chemicals that are used as topical fluorides. So first, coming to the methods of delivery, solutions, if you understand, it is something that is not at all viscous. You can directly apply it like water. It is very thin, I mean it is not viscous, and you can directly apply. The main advantage of solution is it covers the maximum area. Okay, it can go in between the teeth. There is a proper coverage of the tooth surface when you apply it in the form of solution, because the flow is very much higher. But the basic disadvantage of solution is, if you are going to treat the entire oral cavity, you should usually treat it sextant wise or quadrant wise. So it is time consuming. You need to isolate sextant wise or quadrant wise, and then you need to apply. So it is time consuming, and it is because of the increased flow, it is very less retained in the oral cavity, and it easily gets diluted by saliva. On the other hand, the next mechanism is called as gel. Gel we can directly apply using trays. You can simultaneously treat the entire oral cavity, wherein the gel is poured into a tray and the patient is asked to bite on the tray. So simultaneously all the teeth are treated. The problem with the gel is it is more viscous, and hence the flow is not as much as solution. So the advantages and limitations of solutions and gels are totally complementary to each other. One mechanism to overcome that is the use of thixotropic gel. You might have heard of what is thixotropism. Thixotropism is a property wherein whenever there is a force applied, the viscosity reduces. So the patient is, while applying it on the tray, it is gel, and when the patient starts biting on it, or when there is a force applied, it becomes less viscous, or the flow increases, and that serves the purpose of both the solutions and gels. That is currently in use. It is known as thixotropic gel. Another method of delivery is called as the foam. Foam has the least toxicity hazard because the amount of fluoride that is required is much less when you are applying in the form of a foam. It can be sprayed onto the tooth surface. The next is another commonly used method called prophylactic paste. That is usually done after the scaling is done. So after the oral prophylaxis is done, after removal of calculus especially, you can see areas of demineralized enamel or white spot lesions. So when you do the polishing using fluoride containing prophylactic paste, the remineralization of incipient lesion takes place in that method of delivery. And the last method is called fluoride varnish. Now why that is going to be talked separately is, in all of the 5 above mentioned mechanisms, the main disadvantage is that fluoride, how much ever is applied, most of it gets diluted in saliva. And in order to prevent that, if there is a method of delivery wherein you can retain the fluoride onto the tooth structure, the availability of fluoride to the topical effect on the tooth is much more higher, and that is where fluoride varnish stands different from all the other 5 mechanisms. So we'll have to discuss fluoride varnish a bit in detail because fluoride varnish is an important short note question. So as previously mentioned, all the previous methods of delivery other than fluorides, they have an issue with the availability of fluoride after application. They get easily diluted in saliva, and to get a prolonged fluoride action, a person called Smith in 1964 developed a material which is called as fluoride varnish. So here the varnish is coated onto the tooth structure, and the solvent evaporates and leaves a layer of fluoride on the tooth structure. So the next this video we will stop for the present, and in the next video we'll be discussing about fluoride varnish in detail. Thank you.